Hey, CE Impact subscribers, welcome to the Game Changers Clinical Conversations podcast. I'm your host, Josh Kinsey, and as always, I'm excited about our conversation today. Low-dose naltrexone, also known as LDN, has been gaining attention as a potential option for patients managing chronic pain, inflammation, and autoimmune-related conditions. Yet many pharmacists have questions about what it is and how it works. In this episode, we'll break down the basics of LDN therapy and explore how pharmacists can stay informed and engaged in patient conversations about the topic. And it's so great to have a true expert in this space. If you Google her name at all, you will see that that is the case. Michelle Moser is our guest for this episode. So thank you so much for being here, Michelle.
Thank you so much for having me.
Yeah, we're really excited to talk about this. This has been a topic that a lot of our listeners have asked about, and so we're really excited to have some discussions on LDN therapy. So Michelle, for our listeners that don't know you and didn't take the second to Google you when I said it a minute ago, if you'll take just a couple minutes to tell us a little bit about yourself, maybe your practice site. I know your current practice site is retired, but if you could tell us about your career and everything, and maybe a little bit about why you're passionate about the topic.
Absolutely. So thank you again. I'm really excited about presenting on this topic. It's a true passion of mine. So I've been a pharmacist for about 38 years, all over in retail, hospital, specialty pharmacy, but primarily focusing on compounding. And I've owned my own compounding store. Been a member of a variety of networks and compounding accredited areas. What's really amazing is that it gives you an opportunity to network with people who are also really engaged and passionate about a lot of the things you are as well. So as a lot of times we become very aware of certain areas when it hits close to home, right? Mm-hmm. So if there's something going on at home or with our immediate family, then we tend to focus on that. And that's where we really build our specialty areas.
Mm-hmm. Yeah, that's great. Very good. Well, again, thank you so much for taking time to be with us today. And as I always say, I'm excited about today's topic, and it's definitely this because this is, I just don't know that much about this topic. So I'm really looking forward to learning more. So let's jump right in. One of the things I always like to do is set the stage, the foundational stage for our listeners to make sure everybody's on the same page as to what we're talking about. So again, LDN is what we're going to call it throughout the episode, but low-dose naltrexone. So tell us a little bit, what does that mean? Define it for us. What does low dose mean? What kind of range is that? And then we'll just kind of go from there.
Absolutely. So naltrexone as an entity was FDA approved back in 1964. In a typical dose that we see in a retail pharmacy, which is anywhere from 50, 100 up to even 300 milligrams, we usually use that for alcohol overuse syndrome or a variety of other addictions, methadone, heroin, etc. But when we use this medication in a low dose, we actually see very different properties. So the one thing so this is a term that goes way back to when we were in pharmacy school, right? So naltrexone is a hormesis drug. Well, what does that mean? It means that at high dose, it works very differently than it does at low dose. That is really, really important. So when we're dealing with low dose naltrexone, we're usually typically looking at doses of, anywhere from 0.1 milligram to about 4.5 milligram. We might go up a little bit higher. And we do see this in 6, 9, even a few more milligrams, maybe up to 32. When we're dealing with weight loss, we see it combined with bupropion in other realms, other medications for weight loss. And that is also FDA approved. But when we're dealing with low dose, we're going to see that this medication works very, very differently. So we have low dose, then we have very low dose and ultra low dose. So ultra low dose goes down to microgram dosing. And there were some studies done, quite a few years ago, probably back in 2007 or so, that looked at microgram dosing and how it can be actually used with narcotics to enhance the narcotic work so that we can actually help people get off of their medications. So we do see Yeah, we see naltrexone used in very small doses we still use it for alcohol overuse or even opiate overuse. Even though naltrexone intermittently binds to the opiate receptor, that's how it works on some of its mechanisms.
Mm-hmm.
So another mechanism is that it also helps to decrease the interleukin cytokine production. So interleukin 6, 12, those are pro-inflammatory cytokines.
Mm-hmm.
And we heard about interleukin 6 a lot back, 5-6 years ago when we were in the middle of the pandemic, because COVID actually elicits interleukin 6. Well, with naltrexone in small doses, not in higher doses, but in small doses, we can actually block that receptor. So that's where we see some hormesis working. But we also can use it in autoimmune situations because of how it works on Th1 and Th2 pathways. And so we can actually reduce inflammation through those pathways as well. So we're really dealing with 3 primary mechanism of actions when we're dealing with low dose or ultra low dose, very low dose, that sort of thing.
Yeah. Wow. Okay. Very good. That's a lot of great information. Thank you.
Yeah.
So as I mentioned, we've had some learners ask about this. It's been some topic. So is it also a growing awareness within the public sector, like are patients starting to hear about this and being like, oh, what is LDN? What can it treat? What are that kind of thing? I guess maybe just talk a little bit about its public interest, the prevalence of LDN therapy. Yeah.
So low dose naltrexone is not necessarily a medication that is in the commercial space, right? So we compound this.
Mm-hmm.
And because LDN has very few side effects and it has even fewer drug interactions, it can be used in a wide variety of circumstances. So for example, if someone has an autoimmune disease, multiple sclerosis, fibromyalgia, even when we're dealing with thyroid disorders, there's many, many, many more that we use. Scleroderma. I mean, this list is longer than my arms.
Infinite. Yeah. Mm-hmm.
Yes, it really is. Because of one of the mechanism of action that it works, we can actually see it reducing inflammation, but we can also see it reducing antibodies, which I have not found a drug out there that will actually reduce antibodies that the body's producing to cause this issue going on in the body. And we know that there are so many different side effects that can be absolutely debilitating.
Mm-hmm.
Whether they are related in the gut or they pop up on the skin, or even if it's a muscle issue where someone just doesn't feel great and it decreases their ability to work. Mm-hmm. So we're dealing with a medication that is really well tolerated. It's in little tiny doses. One of the key points that I want people to understand, especially pharmacists, is that this medication doesn't have a typical dosing schedule. So we have a start point and we have a kind of sort of end point. But usually when we're dosing low dose naltrexone, LDN, we're looking at a sweet spot for that one individual. So for some people, even with similar disease states, the dose might be 3 milligram. Others, it might be 4.5. But what we found is that a lot of times less is more when we're dealing with LDN. So yeah, we have a typical schedule on how we start to increase the dose. We usually start really low, go slow, increase the dose every 7 to 14 days. So patients are going to need some type of a document, right, to help them all of that, right, and help them track their symptoms as well. But what we also see is that a lot of people are looking for a quick fix, right? Well, this isn't like popping ibuprofen or Tylenol or right, acetaminophen. We're not dealing with gabapentin and nerve pain. We're not looking for a quick fix here. This is something that might work quickly, but probably is going to take months before we see really big changes going on. Yeah.
Yeah.
And it has, and I will say, this is where the pharmacist can really play a pivotal role, is that when a patient has questions, if there's some knowledge that can be
Mm-hmm.
shared, that's when we're going to see better compliance, better
Mm-hmm.
efficacy,
Mm-hmm.
because sometimes it might be 4 to 6 months.
Mm-hmm.
Now, there's a wide variety of books that are available. So I'm going to mention the LDN Research Trust. So this is a nonprofit organization that is based in the UK. They have a variety of seminars. They have a variety of opportunity for learning that may have CE most of the time does not, but they also hold conferences. And this is where a pharmacist can network and really learn about, well, I've got a large autoimmune population. Maybe it's primarily MS.
Mm-hmm.
So where I live in Northwest Washington, we have this band of MS diagnoses. It's really crazy. But we all
Wow.
know that autoimmune diagnoses are very much on the uptick. Unfortunate, but very much so. And a lot of them are based in the gut. So LDN actually helps to reduce inflammation. So if you have somebody with irritable bowel or Crohn's disease, ulcerative
Those are the
colitis.
those are the two I was
Yeah,
going to ask about, if that's
yeah.
something that you've seen treatment for. Yeah.
Absolutely. And there are providers in Missouri that have been studying this for quite some time. So there's, with low dose naltrexone, a lot of information was brought to light in the 1980s. So Dr. Bahari was a physician who was working with AIDS patients. And we all know that during the 80s, we just didn't have a lot of information. What we did know is that alcoholism was a huge impact with a lot of individuals who were diagnosed with HIV before it was full-blown AIDS. So he was handing out naltrexone, not naloxone, but naltrexone, sister drugs, but they work very differently. So he was handing out 50 milligram naltrexones. Well, back in the 80s, we didn't have insurance companies to pay for this. It was all cash. And then
Mm-hmm.
you had to bill your own insurance if you had insurance. Very different game back then.
Mm-hmm.
But what he realized is that his patients were breaking tablets and they were taking parts of tablets.
Mm.
And he was actually watching these T scores, these T cell scores go up,
Mm.
which was unheard of back then. So through Dr. Bahari's work, and then other physicians have, and other scientists have brought up this continual body of work. Dr. Zygon, Dr. McCandless. I mean, there's so many doctors out there that have really, really worked on this. So to date, there are over 930 published articles and research material on low-dose naltrexone.
A lot.
I've been a pharmacist for 38 years. I haven't found a drug that is that well studied.
Yeah.
Is it in the general public? Well, kind of, sort of. Usually a patient is going to bring this material to the pharmacy or to their provider and say, hey, I want to try this.
Mm-hmm.
And a lot of times the providers are going to go, I don't know.
Right.
Because they don't know. It's not commercially available, right?
Mm-hmm.
So where are they getting this information? Well, they're getting this from providers that have information and videos, podcasts like this, a wide variety of other recorded materials that are out on other platforms.
Mm-hmm.
And then you've also got a series of LDN research books. Mm. So there's literally the LDN book, volume 1, 2, 3, and 4. And the fourth book recently came out just a few months ago, and it centers primarily on pain. And when we're dealing with individuals who have acute pain or chronic pain, we're dealing with microgram dosing, not milligram dosing, microgram, right? It's like, what? And we literally start with 1 microgram, and we can use it side by side with oxycodone, hydrocodone, morphine. It does intermittently block those receptors, but what it does is it actually enhances the ability for that narcotic to work in microgram dosing.
Microgram dosing, yeah.
And then we can actually see the medication working better and faster, and people have the better pain control, and perhaps they use less and less often. So we don't necessarily see the habit formation. However, we can still use microgram dosing to help people get off and wean off of their potential habit for opiates as well.
Wow. Wow.
It's a cool
Okay.
drug.
Yeah, I mean, it just seems so versatile. And as you said, I mentioned in our green space before we came on the recording that there wasn't a lot of clinical evidence, but you have, put that to the contrary, because there's a lot of studies and a lot of guidance out there, which is great. So one of the things that you've touched on is, I guess, the pharmacist role. So let's just reiterate that, highlight that, since our listeners are pharmacists, just making sure that they understand. So if I heard you correctly, one of the things obviously is if you're in a compounding space, you can be the individual that's compounding this, but also just having knowledge about it, because either in passing or directly, your patient may question you about it, and whether they're on it, whether they're looking to be on it, whether they're trying to find a provider that will prescribe it, that kind of thing. So what other space can the pharmacist have other than just having some general knowledge about it and finding out more just so that they're in the know? Do you have any other thoughts for the pharmacist so that they understand their space? Okay, please share.
Absolutely.
Yeah.
So a lot of times in the retail space, even in the hospital space, we will see prescriptions come through, right? And so they're going to arrive in the pharmacy and it's going to say Naltrexone. And sometimes it will say like Naltrexone powder, 100%. And a pharmacist in a retail setting has got seconds, right? And usually, I mean, the technician's going to see it first, right? Let's be real. So what do you do with that? Well, there's two different ways to go about this. So I've been compounding for well over 25 years at this point. Can you use a commercially available tablet to make low dose naltrexone? Well, let's talk about this a little bit, because there are some forums out there where patients have chimed in, and even providers have chimed in and said, oh yeah, you can definitely do this. And this is what they're telling patients, even providers, and this makes my hair curl. So providers are writing prescriptions for 50 milligram tablets and telling patients to dilute them. There's also a thought that,
I'm already on edge.
Yeah, and I'm like, there's also there's a couple of people out there that think that you can separate the lactose in the naltrexone tablet from the active ingredient by dissolving it in water. And anyway, no, I don't think that really works very well. So let's talk a little bit about that area, because we will see that everywhere. So generic drugs that are made in the United States are allowed to vary plus or minus 10%, right? So they're never, a 50 milligram tablet very rarely is going to be 50 milligrams. Very rarely, right? It could be as little as 45 and it could be as high as 55, which I doubt it's really ever going to be a lot more, but it's usually less. So if we're dealing with a medication that the patient has to dial in on a very, very, very small dose, how are you going to know if that tablet that you're asking them to dump in, a 50 milligram tablet, dump in 50 mils of water? First of all, how are they going to measure that? How are they going to store it? What kind of water are they really using? Are there contaminants? Are there impurities? Okay, so you see where I'm going with this?
Absolutely.
So it really, really, really needs to be compounded. Because accuracy is so important. It literally will mean the difference between a patient's success and not with this medication. And we're all here to help patients. We're all here to ensure that a patient's questions are being answered. But really, by the time they come to low-dose naltrexone, they have probably spent years, if not decades.
Right.
And how many providers?
Yeah.
Right? Because they're dealing with these chronic issues that they really don't get a lot of answers to. So really important, have it compounded. Please find a really good compounder that understands, that is sending their materials out for testing, and also understands that when they are using a bulk powder, active ingredient, are they using the base or are they using the hydrochloride salt? Because you've got to correct for the salt as well.
Interesting.
So then we can also meet the patient where their needs are need to be fulfilled. Do they need a liquid? Because you can actually manipulate that liquid a little bit better. So let's find a base that's going to work for them. Because by the way, naltrexone powder is bitter. Ay, ay, ay. It is bitter.
Mm-hmm.
So a good compounder is going to find a base that's going to work for the patient. A lot of times it's an oil because you're going to have a great or a better beyond use state. You can extend it out 90 days versus 30. Patients are not very happy about having to buy a prescription every 30 days.
Over and over. Mm-hmm.
Compounded a lot of times is out of pocket.
Mm-hmm.
We can flavor it. We can use a bitter block. We can use all kinds of things to help make it a little bit more palatable.
Mm-hmm.
Or we can compound little itty bitty capsules, little tiny dose capsules. Yeah, they're going to end up taking a handful of them, but we can find that very specific dose for them.
Mm-hmm.
Because like I mentioned earlier, a lot of times with naltrexone, less is more. So again, this is where the pharmacist plays a key role. Patients are going to have questions. All of a sudden, they're going to have these, what they assume are side effects associated with the last medication that they just started, which is LDN. Well, now I've got, I've got this terrible gut ache, or I've got a headache, or, I've got a rash, and maybe it's the LDN, maybe it's not. Maybe it's the autoimmune disease that's popping up and it's flaring. Maybe they actually have a yeast infection, a fungal infection. If they're using LDN for Lyme, they may actually have reduced the inflammation enough where the underlying disease pops up and they have a bloom. And this happens with fungal infection and yeast infection as well.
Mm-hmm.
So what happens is the patient feels yucky, right? They all of a sudden they've got this outbreak of something that they're not very happy about. And, oh, that was that drug that caused that. I'm just not going to take it anymore. Well, you don't necessarily know about it. The doc will never know about it unless you tell them, because they'll just stop taking it and then they won't go back, or it will be months or years before the patient actually gets back in contact with the provider. So if a pharmacist has a follow-up program that can allow for the patient to interact with someone at the pharmacy team member, ask questions, answer questions, and there are some platforms, some electronic platforms that are available that the patient can actually use. So it's not necessarily a phone call that's, going to take an hour and a half of your time, which we don't have.
Right.
There are some electronic platforms that allow for that. So it's really about building that relationship.
Yeah.
The provider's not going to have the time. The nursing staff's not going to have the time. But that's where, again, we are forefront in dealing directly one-on-one with that patient.
Yeah. So even if it's as simple as you see a naltrexone prescription come across your desk, maybe questioning that, is it maybe having that conversation with the patient? What is the doctor prescribing this for? What are you using it for? And finding out if they're going to be putting it in water at home, and then, circling back to making sure that they're getting that through a compounding facility instead. So that, I think is the simplest step where a pharmacist can be involved, is just making sure that they're aware of the prescriptions that are coming across, what the patients are taking. And then, like you said, if it is something that they're have officially been prescribed, or the pharmacist learns that they've been on it, it's a good idea just to be in the know so that you're aware of it. You can have the conversations, you can continue to promote compliance and adherence and things like that. So yeah,
absolutely.
That's great. So you've touched on a little bit of the mechanism of action and how there's at least it's different with the low dose and whatnot. Is there anything else in that space that you want to be sure you convey to the listeners?
Absolutely. So again, we're dealing with a hormesis drug. So at a typical 50 milligram dose, we do use it for alcohol overuse syndrome, methadone withdrawal, that sort of thing. When we're dealing with low dose naltrexone, we don't have the same side effects. We don't see the liver impairment that is a potential issue with a larger dose. We're dealing with doses that are perhaps up to 4.5 milligrams. Sometimes we'll go up to 6. It just really depends. So there's a wide variety of guidelines and written materials that are really easy to access. And again, that through the ldnresearchtrust.org, you can definitely access even some of the calls that are available. The first chapter of each of the 4 books literally goes over step by step the 3 main areas of action with low dose, very low dose, and ultra low dose naltrexone. So I really encourage people to dig. I had reference copies in the pharmacy because if somebody came in and they were dealing with chronic pain, I could go to those chapters. If they were dealing with cancer, I could go to those chapters. If we're dealing with ulcerative colitis or Crohn's, again, different chapters, different providers. But when we're dealing with thyroid, if somebody has autoimmune, Hashimoto, Graves, we can use low-dose naltrexone to help with those situations as well. But again, the pharmacist needs to know at what point do we start looking at other labs. For example, if someone is on levothyroxine and hopefully lidocaine as well, T4 and T3, and they start low-dose naltrexone, those labs need to be drawn 4 to 6 weeks after starting LDN. Well, why? Well, because the thyroid will act very differently if the antibodies decrease and function of the thyroid starts to normalize. So T3 is the only active component of thyroid, right? So T4 is hopefully being converted to T3. That's another enzymatic issue that may or may not happen. However, again, this is where the knowledge becomes very, very important, because you don't want to swing somebody from a hypothyroid state to a hyperthyroid state, right? That's because we're usually dealing with people who, and a lot of times are women. Men are affected by thyroid issues as well. However, the majority of them are. We don't want to all of a sudden have their doses really wonky. We don't want to add to the potential of osteoporosis. So you can kind of see the cascade and the ball starting to roll downhill and become a bigger issue.
Yeah.
Knowing when that needs to happen is very important.
So Michelle, you've given us so much information, and I just kind of want to recap some of the challenges that we've seen, because you've given us so many strategies to overcome those challenges. And so one of them is, one of the things that a pharmacist can be available for and can be there to support the patients is ensuring that when it is being compounded, when LDN is being prescribed and compounded, that it's being used appropriately, helping with adherence and pushing that forward as well. Because as you said, sometimes that's a challenge with a patient, and it does take a long time sometimes to see those results. So again, just the pharmacist understanding that and being there for supporting the patient and kind of cheering them along, I think goes a long way. And then the other thing that you had mentioned, obviously, was being aware of, if we see a prescription come across our desk and we maybe are concerned that it's going to be compounded at home or something like that, to really step in, discuss, the necessity of having that officially compounded by a compounding pharmacy, so that we can maintain product quality and get the right formulation. And I love how you shared about all the different formulations, because that was one of my questions. And I think to me, that is one of the beauties of compounding, is that customization for the patient. And
Absolutely.
I know that that's something that you're passionate about too. You love that whole idea of customizing. So that's great. So much good information here. Before we wrap up, I just want to reiterate, you set me straight earlier on, because I said there was limited research, and you made sure that I knew there was lots of research, and that is fantastic, because that's a misconception. And so I think that that's important that our listeners hear that. So just reiterate, if our listener is wanting to know more, what next steps should they do? Where should they go to learn more about LDN?
Oh, there's so many resources. There's other online platforms, there's social media, there are materials available in print. Like I said earlier, there's well over 930 articles, and some of them go back to the 80s, and that's okay. But really, most of these are maybe 20 years old. So this is fairly recent material as well. What's amazing is that there is one summary document. And I call it the Dartmouth article because it was written by two researchers at Dartmouth University. It was published in 2007. And it's available online, and it talks about how LDN works, mechanism of action, dosing range, patient outcome, that sort of thing. So it's a great tool to have, not just in the pharmacy, but also to hand out to providers. But really, the low dose naltrexone, or the LDN Research Trust, this is a nonprofit organization based in the UK. That really is the go-to for a wide variety of information. There are several books out there, LDN book, volume 1, 2, 3, and 4, catchy names. They're available on Amazon. You can get them through the Research Trust as well. They are easy to read. They're all patient studies. They're not a sales gimmick. In other words, these books were written by case studies by the providers that actually made or developed the case studies, real patients, real pictures, and they talk about what to do, what not to do.
Yeah.
And they also talk about the dosage range, which is cool.
Yeah.
Compounding meets patients where they need to be. So if they need a tablet, a capsule, a liquid, a ready dissolve wafer, anything like that. We even use naltrexone topically. Well, actually, we use it topically for like itching and things like that. We can use it transdermally for children. And there's also eye drops to help with a wide variety of ophthalmic issues. So this is where compounding is cool. But the real message is that low-dose naltrexone is one of those medications that can literally deliver hope. And that is something that, as a knowledgeable pharmacist, or at least knowing where to find research materials, where to find resources, that sometimes is enough. But if you can give hope to someone who's been battling, suffering, dealing with issues for years, maybe even decades, been through many, 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 many providers. But if you're that one person that can deliver a message of,
there might be something.
There might be something. It might, it's going to get better. And this is how. It may not be tomorrow that you're feeling 100%. It might be 4 months down the road, but we probably aren't going to get you to 100%. But if you're at 75%, it's a whole lot being better than being at 20%, isn't it?
Exactly. Yeah. I love that. So that is, listeners, if you couldn't tell, that's Michelle's game changer for the day. So being that person, she's empowering you to be the game changer, learn more about LDN, be in the know, and be able to talk to your patients. It's also something, this is low-hanging fruit, we didn't even talk about it, but if you have patients that have an autoimmune disorder, maybe you bring up the subject with them, especially if you know that they've been struggling with their quality of life, or if they've been struggling with specific, issues or adverse events. So again, being in the know and offering that hope, that's our game changer for this topic. So yeah, thank you so much, Michelle, again, for giving of your time and your expertise. I can tell that there's still about 6 hours at least of content in your head to share with us. So yeah, so we'll definitely have to look at extending this, and I'm anxious to see the response we get from our listeners, because I know it's just a topic that keeps coming up, but nobody really knows a lot about it. So thanks for shedding some light on it. Really appreciate it.
Happy to. Thank you so very much for having me. And again, if there's anything else I can do to help, please let me know.
Thank you so much.
All right, take care.
Thank you. If you're a CE Plan subscriber, be sure to claim your CE credit for this episode of Game Changers by logging in at ceimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you all again next week.